What's up, Ninja Nerds? In this video today, we're going to be talking about hypertrophic cardiomyopathy, sometimes referred to as hypertrophic obstructive cardiomyopathy. If you like this video, it makes sense, you benefit from it, please support us by hitting that like button, commenting down in the comment section, and please subscribe. Also, if you guys want to follow along with some amazing notes, some awesome illustrations, go down the description box below, click on the link that'll take you to our website where we have some amazing notes and illustrations to follow along with. All right, Ninja Nerds, without further ado, let's talk about hypertrophic cardiomyopathy. So cardiomyopathy in general, as we talked about before, is a dysfunction, disease process of the myocardium of the heart, particularly affecting like the ventricles, and that being said, more likely the left ventricle, but it can affect the right ventricle. When there's dysfunction of those actual myocardial tissues of the ventricle, right, it's usually not due to an ischemic cause, such as like a myocardial infarction, or it's not due to a valvular disease, such as like an aortic stenosis or mitral regurgitation. It's usually due to something else. We talked about how dilated cardiomyopathy is the most common type of cardiomyopathy. 90% of the cases are usually that one. The second one, the runner-up in this case, is hypertrophic cardiomyopathy. Now, what is the cause for someone developing hypertrophic cardiomyopathy? Well, it's actually really interesting. So there's two ways that you can look at it. One of them is it's actually due to, it's an autosomal dominant disorder. So what can happen is there can be particularly an autosomal dominant disorder that can develop, early. It could be sporadic, it could be familial, but usually what happens there is some type of mutation within the proteins that are involved in your sarcomere. Your sarcomere, that's a structural and functional unit of particularly the muscle cells. Your actin, your myosin, your troponin, your tryptomyosin, all those different proteins are very significant to the sarcomere. So there's a mutation within one of those proteins. And so then one of the proteins is actually, it's actually nice to remember it like this, it's the heavy chain of myosin. It's technically the beta subunit of the heavy chain of myosin. But that is particularly where the mutation is the heavy chain of myosin. When you alter this protein, it leads to decreased sarcomere function. And if you decrease the function of the sarcomere, you particularly reduce cardiac function. And so that's a problematic issue, right? If we reduce sarcomere function, we have to come up with a way to compensate for that. And so what happens is this triggers this very interesting type of process we'll talk about here in a second. But this is the first one. So an autosomal dominant type of disorder that can develop usually either sporadically or it could be some type of familial process where there's a mutation in the gene that makes that protein that reduces sarcomere function. The other one, this one's interesting. This is actually what's called a trinucleotide repeat disorder. And this disease is called Friedreich's ataxia. Friedreich's ataxia is a genetic condition. It's a trinucleotide repeat, particularly GAA, that causes alterations within some of the proteins that are a part of the sarcomere. So there could be alterations in very specific types of proteins. And one of the proteins is it could be proteins of the myocytes. So there could be proteins that are altered in the myocytes, especially the cardiac cells. But it can also alter proteins within your central nervous system as well. So again, it also affects your central nervous system proteins as well as the proteins involved in the pancreas. And you'll see why we mention that in a second, because there's actually a very specific triad behind someone developing Friedreich's ataxia. They develop what's called hypertrophic cardiomyopathy due to the myocyte process, and they develop what's called ataxia due to the involvement of the central nervous system, very specifically the spinocerebellar tracts. And they cause diabetes mellitus, right, due to involvement of the pancreas. So these are big things. If you remember the triad, it's usually neurological involvement, diabetic involvement, and hypertrophic cardiomyopathy for Friedreich's ataxia. So again, it could be Friedreich's ataxia, or it could be some type of mutation, whether that's familial or sporadic. More commonly, it's likely to be 50% familial or 50% sporadic. You develop a mutation in that gene. Regardless, what happens, here's why it's really cool. So we're going to look at this in two ways. We're going to look at it in this diagram and this diagram. What happens is that whenever you have a reduction in that sarcomere function, yeah? So there is, son of a gun, there's a reduction in the sarcomere function. your cardiac myocytes are like, man, we got to come up with a way to be able to function properly so we can maintain good cardiac performance. And so what happens, this triggers your actual cardiac cells. So your cardiac cells, hey, man, I don't like this. I don't like that we're having these sarcomeres, they're not working really well. I'm going to increase the secretion of different types of growth factors. And when these growth factors are released, it's going to try to stimulate an increase in myocyte growth and thickness. So it's going to cause them to grow and to multiply and to get bigger and thicker. And so this is really cool. When there's this increase in myocyte growth, we can see this in two ways. I like to look at it in both views. So imagine in this scenario here, we look at this actual left ventricle, right? Take a look at the left ventricle. Here you have the free wall of the left ventricle. And then here you have the interventricular septum. You notice something that's just popping out at you? My gosh, look at the thickness of this interventricular septum. That son of a gun is big. Because of this type of disease process, when the myocyte growth occurs, it doesn't occur symmetrically throughout the entire ventricle. It occurs asymmetrically and tends to particularly involve the interventricular septum. And so the most commonly affected area of the heart is the interventricular septum. So that's one way. Now think about it like this. Again, here's a normal heart, right? Right ventricle, left ventricle. I'm just cutting up right here. You can't see the atria above. And what happens is, here's your interventricular septum. You go through this process where the sarcomeres aren't functioning. You have this increased growth factor release. Whenever that happens, you start stimulating these myocytes to grow. They grow in a haphazard, asymmetrical fashion. And then now look at my interventricular septum. Look at the thickness between this one and compare to the free wall. What is this called again? This is a asymmetric hypertrophy. Beautiful, okay? Now, here's the next thing. If we not only think about this in a global, macroscopic type of appearance of the ventricles, we looked at this actually at the cellular level, the histological level. What would this look like? Let's come down and take a second here. All right, so now go back and think about this, right? So here's this actual myocyte. This myocyte, there's some type of mutation, whether that be due to Friedreich's ataxia, causing a trinucleotide repeat, altering the proteins of the sarcomere, or whether it's due to some type of mutation that's causing a mutation somewhere within the heavy chain of myosin. But there's a disease process here. It's altering the sarcomere function. Because you're altering this sarcomere, you're altering this sarcomere structure. When you alter the sarcomere, these cells start releasing lots of growth factors. And when the growth factors are released, it causes the myocytes to try to grow. But you know how not only does it grow in an asymmetric fashion at the interventricular septum, the myocytes do not grow in the way that we prefer them to grow. Yes, it causes asymmetric hypertrophy in a macroscopic view, but in a microscopic fashion, it causes two things. One, it causes these myocytes to grow in a very haphazard way. And we call this myocyte disarray. The other thing that happens here is that when the actual myocytes are growing in this very haphazard type of fashion, you know what else? When the sarcomeres are whenever you're growing these myocytes, increasing their size, you do this through a process called concentric hypertrophy. Unfortunately, this hypertrophy that is occurring, it's not occurring symmetrically, obviously. And what this means is, look here at this sarcomere. You see how we have this one that's lined up here within this cell? Now look at these muscle cells. We're growing these in a parallel fashion. Whenever you grow these sarcomeres in a parallel fashion, it causes the actual myocardial, so the ventricular septum to get thicker, right? And narrow the lumen of the actual ventricular cavity. And so this is called concentric hypertrophy. This not only occurs with hypertrophic cardiomyopathy, this occurs with other diseases that have high pressure where they have to respond. You know, aortic stenosis, hypertension, ischemic cardiomyopathy. These are particular things, but this is what I want you to remember. Genetic mutation, autosomal dominant condition, particularly for one of them, where it's familial, sporadic, heavy chain of myosin is altered. Second one, Friedreich's ataxia. What happens? Alter the sarcomere, they release growth factors, myocytes grow, but they grow in two ways. One, asymmetrically, where it affects the interventricular septum, and it's much, much more thicker at the interventricular septum in comparison to the free walls. And second, on the microscopic level, it causes a myocyte disarray, very disorganized growth pattern, and the way by which these cells get bigger is it's called a concentric hypertrophy, where the sarcomeres are added in what type of fashion? In a parallel fashion. Parallel type of fashion. So that is what I want you guys to take away from this process here. That will discuss the causes. Now, let's get into the pathophysiology and complications. All right, let's talk about the pathophysiology and complications of HCM, hypertrophic cardiomyopathy. So in this condition, we know that there is an increase in the growth of the ventricular myocardium, right? Particularly the left ventricle. And when it occurs, it does affect the entire left ventricle, but more so it affects that interventricular septum. That's why you get an asymmetric hypertrophy of the interventricular septum. But don't get it twisted. You get hypertrophy of the entire left ventricle. Now, with that being said, if you have an increase in the actual left ventricular thickness, right? So there's increase in left ventricular thickness. Right? Thickness, baby. What's that going to do? It makes the left ventricle a little bit less compliant. All right? Doesn't want to stretch as much. All right? So less compliant is what I want you to think about. So decrease left ventricular compliance. Think about that as being less stretchy. If there's a decrease in left ventricular compliance, right? So the blood is coming in from the atrias and going into this left ventricle. When it goes into the left ventricle, think about it. Look how little the lumen is there for that left ventricle. There's not a lot of space. So not only is there a thickness of the left ventricle that's decreasing the compliance, not making it want to stretch as much, but also there's just less space within the left ventricle. That son of a gun is very, very thick to where it's making very little space within the left ventricular lumen. So because of that, that alters the filling process. When blood is coming in from the atria into the ventricles, that's called diastolic filling. If the left ventricles are thick, causing it to have a decreased compliance and decreased cavity size, that's going to reduce the diastolic filling process. If you reduce the diastolic filling process, what is that called? You reduce the preload. If I reduce preload, then I effectively will reduce stroke volume and then eventually reduce my cardiac output. Okay, well that's interesting. So that's one thing that I can have here. You know what they call this whenever you have this reduced diastolic filling process because of the increased left ventricular thickness, right? Again, remember, there is a significant asymmetric hypertrophy, way more on the left ventricular, interventricular septum, and less on the left ventricular free wall, but they're all there as thickness. This right here, whenever the ventricular myocardium is really thick and less willing to expand or allow for volume to come in, this is called a diastolic dysfunction. It's not responding to the diastolic process to accumulate and let blood come into them. So they are not very good at being able to allow for good preload. So diastolic dysfunction is a process here. Now, what happens over here in another situation? So we got a problem with diastolic filling due to left ventricular thickness, decreased left ventricular compliance. Here's another particular issue. Okay. Now, when the left ventricle has to contract, so here's your left ventricle, yeah? You want to pump blood out of this left ventricle and into the aorta to pump out to your systemic and coronary circulation. That's the whole goal. When the left ventricle has to contract, I want you to think about it like this. All of these areas have to move towards the center. Yeah? All of these have to move towards the center of the cavity because they're all trying to squeeze onto the blood to push it out. When that happens, look what will happen here. Imagine that was the normal size. Now this left ventricle, so let's actually do this here. Here was the original size. It's going to contract now. I'm going to do this. I'm causing it to contract even more. What am I doing to this? I'm causing it to bow in even more into the lumen. Oh, shoot, son. If I cause this interventricular septum, when it contracts, to bow into the lumen, look what that's doing to my left ventricular outflow tract. You see this area right here that I'm going to have in blue? See this? That's called my left ventricular outflow tract. Okay? That's narrowed. And that's narrowed. That's going to reduce blood, the amount of volume of blood that I can push out of the left ventricle into the aorta and out into the systemic or coronary circulation, right? Here's another thing that happens. It's actually really cool. When we try to push blood through that tiny little area now because of this interventricular septum dynamically moving in and obstructing that LVOT, it creates something called the Venturi effect, okay? So that's your left ventricular outflow tract. We are good with that now, okay? What happens though is that when that dynamic obstruction occurs from the interventricular septum bowing in, it causes this valve. You see this leaflet right here? This is your mitral valves. This mitral valve leaflet gets pulled inwards towards this septum. It gets pulled inwards. And it almost coapts and touches the interventricular septum, right? And it's because whenever you're trying to push blood through that small little area, it yanks the actual anterior leaflet of the mitral valve towards the interventricular septum. You know what they call that? They call that the systolic anterior motion of the mitral valve. So let me go through and explain what happens, right? The left ventricular, the interventricular septum contracts. When the interventricular septum contracts, that's going to narrow the left ventricular outflow tract, that little area in blue, okay? When you narrow the left ventricular outflow tract, that causes what's called the Venturi effect. And the Venturi effect is as blood is flowing through, really high pressure, high volume of blood, high pressure blood is running through that small little narrow left ventricular outflow tract, it creates kind of like a vacuum suction that pulls the anterior valve, the anterior leaflet of the mitral valve towards the interventricular septum. So we call that movement systolic anterior movement or motion of the mitral valve. And that causes a obstruction of left ventricular outflow tract. If we get less blood out of the left ventricular outflow tract, not as much blood is getting out of the ventricle, that is called a reduction in stroke volume. And a reduction in stroke volume is a problematic issue. So why is this an issue? We have a reduction in stroke volume due to reduced diastolic filling. And we have a reduction in stroke volume due to something like an obstruction. But this obstruction is a very specific term. We call this a dynamic interventricular septal obstruction. And when that happens, it narrows the left ventricular outflow tract because you're bulging into that area, creates the Venturi effect, pulls the anterior leaflet of the mitral valve inwards towards that septum, called the systolic anterior movement of the mitral valve, completely blocks off the blood flow to that left ventricular outflow tract, and you significantly drop your stroke volume. Why is all of this stuff problematic? I don't want you to forget these two terms. That's the whole point of talking about these. These two things lead to less stroke volume. If less stroke volume is occurring, what does stroke volume determine? So we know that heart rate times stroke volume is equal to cardiac output. So if we reduce our stroke volume, we're going to reduce your cardiac output. If you reduce cardiac output, you're reducing the blood flow out into the systemic circulation. So now there is a reduction in systemic cardiac output. What's one of the symptoms that can develop from that? Imagine you have a significant outflow tract obstruction, you don't get enough blood flow to the brain. You don't get enough blood flow to the brain and you're trying to exert yourself and go running and all of that stuff, and guess what happens? You just go to sleep. You have a syncopal event because of significant reduction in perfusion to the brain tissue. So this can lead to a syncopal event. Here's something that's even worse. You know what else? What blood flow comes off right at the proximal portion? Right off of this proximal portion here, there's some vessels that come off here that supply the myocardium of the heart. What are these vessels? Your coronary vessels. If there's a reduction in cardiac output, you're going to have a reduction in coronary perfusion. Oh, shoot, son. If we reduce coronary perfusion, that is going to be a very significant problem. Now, less blood flow is getting to the myocardium of the heart. If less blood flow is getting into the myocardium of the heart, you're going to have ischemia. And this may produce angina. This may produce other symptoms like dyspnea on exertion. Yeah, so that may be another one. Dyspnea on exertion. But that stuff isn't too bad. What's the scary thing? You get to the point where so much ischemia is occurring here. When there is an intense amount of ischemia to the myocardial cells, they become more permeable. When they become more permeable, cations can start leaking into them. And when these cations, like calcium and sodium, start leaking in, they cause these cells to become hyperexcitable. And when these cells become hyperexcitable, especially within the ventricles, you can end up going into what's called VTAC or VFib. And you know what the problem with VTAC or VFib is? It can push you into sudden cardiac death. This is why in the clinical vignettes, if you have a patient with hypertrophic cardiomyopathy, you know what's the most important thing to think about is you have a patient, it's genetic. So usually this is going to happen in a younger patient, less than 35 years of age most commonly. And usually the clinical vignettes will present this as someone who is exercising, a very intense athlete. They've been working out really, really hard. So they're exerting themselves. When they're exerting themselves, their contractility is increasing really, really intensely. When they're contracting really intensely, guess what they're doing? The interventricular septum is bowing in and blocking the outflow tract. Their diastolic filling process is reduced. Their stroke volume is reduced through these processes. Less cardiac output, less perfusion to their heart. They go into a quick VTAC, VFib and pass out and die in usually some type of event. And that's the big thing that you want to remember. This is the scary thing that can happen with these patients, is they can have a fatal arrhythmia and go into sudden cardiac death. Usually patients less than 35 years of age who are presenting with angina, dyspnea on exertion, they have syncopal events during an athletic event. Be thinking about this on your exam. Okay, we got that down. Now that we've thought about these particular issues, there's some other things that we need to know that is very, very important for your exam. Now, you know that dynamic obstruction, yeah? So whenever a patient has that dynamic interventricular septal obstruction, that's going to produce a very interesting type of murmur. Okay? So what happens is left ventricle will contract. When it contracts and squeezes down on the blood, again, this interventricular septal will do what? It'll bow inwards, obstructing that left ventricular outflow tract. When blood has to squeeze through that area, it'll produce a murmur. So it'll produce a very interesting type of murmur. And that murmur is occurring during systole. So this murmur is called a systolic ejection murmur. And what I want you to remember about this is, here's what's really cool. Whenever this murmur occurs, right, so you know whenever you have your first heart sound, so here we have something like this. Here's your S1 heart sound, and then you have your S2 heart sound. So this is kind of how your heart sounds would work, yeah? S1, S2 heart sound. During the systolic process, which is kind of in between S1 and S2, the blood will start flowing out. When it flows out, it hits that obstruction. When it hits that obstruction, as the blood is moving through this area, it gets intense, it gets more intense. And then, after it passes through that obstruction, eventually the anterior mitral valve leaflet will kind of go in and block it out. And so almost like no blood is getting out, this actual murmur will decrease. So what happens is your murmur increases in intensity, and then it decreases in intensity as we go through the systolic process. You know what they call this when it looks like this type of process? They call this a crescendo, decrescendo type of murmur. That's a big thing to remember, okay? So one of the other symptoms is if you're auscultating a patient, you're listening over that actual area of the heart, you may hear a systolic ejection murmur between S1, S2 that sounds really loud in the beginning of systole and then veers off during the end of systole. When you're auscultating, here's another issue. What do we say? There was a decreased left ventricular compliance, yeah? And that was due to the left ventricle being super thick, not having a lot of space. What happens is, when the left atria has to bring blood into this left ventricle, right? It has to bring blood into the left ventricle. the left ventricle is not a big fan of trying to let that blood come in. And so what happens is the left atria is trying to push blood into the left ventricle, but the pressure is just too high that the left atrium can't push the blood down in there, because this pressure in the left ventricle is just too high because there's very little space, right? So lower volume, higher pressure. Because of that, the atria get ticked off, man. They're like, the heck with this. And they say, I'm gonna go bulk season on you, and I'm gonna start thickening up myself as well. And the left atria starts increasing in hypertrophy. So this leads to left atrial enlargement and left atrial hypertrophy. Now the left atria is all jacked up on steroids, and whenever it contracts, that bad boy contracts and pushes blood into this very decreased compliant left ventricle. And when that happens, it produces a heart sound called a S4 heart sound. And this S4 heart sound is usually indicative of a diastolic dysfunction of the heart. Boom, roasted, we done hit that one good. Okay, the next thing you want to think about here is, remember, what did I say happens whenever this interventricular septum, when it kind of bows inwards? It narrows the left ventricular outflow tract, right? So you produce what's called that dynamic, going back to that dynamic obstruction. What it did is it caused a narrowing of the left ventricular outflow tract, right? When it narrowed it, what did it cause? The Venturi effect. The Venturi effect does what? Causes the systolic anterior motion of the mitral valve. This anterior leaflet goes this way to try to coapt near that interventricular septum. If that valve is going this way, now whenever the left ventricle has to pump blood, now watch this, if that valve moved this way, I'm going to do it purple for this reason here. If that valve moved this way, now look, when blood is supposed to be flowing this way, it now has a direct avenue to go right into the left atrium. And because of that, this can produce a mitral regurgitation murmur that can be heard. And this is a holosystolic murmur. Don't forget that. So we have an S4 heart sound, and we have a mitral regurgitation murmur due to the systolic anterior movement of the mitral valve. Last thing, whenever blood is exiting out, right? Whenever the blood, so you have that dynamic obstruction again, one more thing can happen. You get the narrowing of the left ventricular outflow tract, right? When that happens, blood will still get out, and you'll produce this little peak on your arterial pulse. So if you look at an arterial pulse, you're actually palpating, or you have an arterial line and you're looking at the waveforms, you'll get this, boop, a little hit there. And that's that first part of the pulse, right? But because they have this dynamic obstruction, once the anterior leaflet of the mitral valve moves over and blocks that area, what happens is you get this delay where what happens is less blood will actually come out into the aortic vessel. And then what happens is eventually the pressure in the left ventricle has to overcome all of that obstruction and push even harder. And it does that and produces a second little peak. And you get this interesting little biphasic pulse. They call this pulsus bisphorensins. I'm not going to write that out. There's another name for that. It's called a biphasic pulse. And this is a very important thing to also remember in patients with hypertrophic cardiomyopathy. So, systolic ejection murmur, boom, crescendo, decrescendo. S4 heart sound to the diastolic dysfunction. The dynamic obstruction could produce two different things. One, mitral regurgitation murmur due to the movement of the anterior leaflet of the mitral valve. And also, if you're checking a pulse, you may hear a boop, a high little pulse that you actually feel with the first part of the pulse, the aortic waveform. You may feel a first pulse and then a drop, and then boom, another pulse. And that biphasic pulse you can see in HCM, hypertrophic cardiomyopathy, as well as aortic stenosis. So don't forget that as well. All right, now that we got all these down, the very high yield thing is to go back to this systolic ejection murmur, because one of the things that you will be tested on, I can guarantee it, is maneuvers that we can utilize to increase the intensity of this murmur or decrease the intensity of this murmur. Let's talk about that. All right, so when we talk about the systolic ejection murmur, we can alter the intensity of the murmur by doing specific maneuvers that we don't probably do in the true like clinical world, but it's important to remember for your exams. So first things first, we can alter that actual crescendo decrescendo murmur by changing the preload. All right, so here's what I want you to think about. What would happen to this dynamic? Think all about that dynamic obstruction. Okay, that's all I want you to think about. What are the ways which we could, cause that dynamic obstruction to be less or more intense? So first thing, what would happen if we increase preload? All right. So if we increase preload, meaning more blood is going to come from the atrium into the ventricle. If more blood comes into the left ventricle, what would that do? It would stretch these ventricles out a little bit, right? The more blood you have in this area, the whole thought process behind that is that you would increase the size of that left ventricle, hopefully. And maybe, just maybe, I move that obstruction a little bit farther away. I open up my, what? My left ventricular outflow tract just a little bit. So with an increase in preload, I decrease the obstruction because I stretch the ventricle out a little bit more. Obviously, this is a significant over-exaggeration, but you get the point. More preload, more volume, hopefully it stretches out the ventricle and decreases the obstruction. If you decrease the obstruction whenever blood is exiting out of the ventricle and out into the aorta, would that cause the murmur to be more intense or less intense? Well, I'm removing the obstruction, so I'd assume it'd be less intense. You're right, my friend. So an increase in preload decreases the obstruction, and the significance of that is that this will decrease the intensity of the murmur. All right, beautiful. So my question for you is, what things will increase preload? What's going to increase the return of blood to the heart? That's a good question, yeah? So that would be if you want to increase the venoconstriction mechanisms. So I want to get more blood to come up to my heart. So what if I squatted down? If I squat down, I squeeze down on those veins and push blood up. So squatting would be one particular way which I could do this. What else could I do that would actually cause this process? Well, the other one that I could do besides squatting is I could also particularly have someone do what's called a passive leg raise, right? So what's something called a passive leg raise. So what I do with a passive leg raise is I lift the leg up. And if I'm lifting the leg up, I'm actually causing more blood to flow by gravity down and upwards to my actual heart. So that's trying to increase the venous return. So if I were to have someone squat down and they had HCM, their murmur intensity would decrease. If I did a passive leg raise, increasing venous return, their murmur intensity would decrease. Obviously, with this being said, what would happen if I reduce the preload, my man? If I reduce the preload, now think about this in the opposite scenario. If I reduce my preload, that means less blood is coming into the ventricles, right? If less blood is coming into the ventricles, my ventricles aren't going to stretch as much, right? They're not going to want to accommodate, they don't have a lot of volume that they have to accommodate. And so because of that, less volume in here means that my ventricles don't have to stretch out as much and relieve that obstruction. So now there's a worsening of the obstruction. So reduction in preload is going to increase the obstruction. And if I increase the obstruction, that is going to increase the intensity of the murmur. Oh man, we good. All right, so what kind of things would reduce my preload? One thing is I'm not squatting, I would instead be standing. I have no particular muscles that are really working hard to squeeze the blood flow up. And then the second one is actually a very interesting maneuver called the Valsalva's maneuver. You know, Valsalva's maneuver is what you do when you drop a deuce. You're just what you do when you do that process is you kind of close off the glottic airway, reduce air from flowing out, and that increases the intrathoracic pressure. Now imagine pressure here in the thoracic cavity is high, and your inferior vena cava, which wants to bring blood into the heart, yeah? It wants to bring blood in, there's lower pressure in the abdomen. What does blood like to flow? From areas of high to low or low to high? high to low. But now the blood from the inferior vena cava has got to go up into this high pressure system in your chest cavity. It's not going to want to flow against that. And so less blood will enter into the heart because the pressure is too high here. And so that could potentially increase the intensity of the murmur. So if you had a patient, you had them standing, they have HCM, it would increase the intensity. And if you had them Valsalva or bear down, it would increase the intensity of their murmur. Okay, what would happen to this murmur if we changed afterload? All right. So afterload is what? How do we define afterload? It's the amount of resistance within the systemic vascular, it's the amount of resistance within the actual vessels, in this case the aorta, that the left ventricle has to overcome to push blood out into it, right? So the higher the resistance or the pressure is outside in this aortic vessel, the harder the left ventricle is going to have to work, okay? So I want to think about things that would either increase my afterload or things that would decrease my afterload. Okay, so if I increase my afterload, now this one is tricky. It took me forever to figure this one out. Okay, ready? High afterload. If you have a high afterload, that is going to do what to your actual stroke volume? What is the relationship between afterload and stroke volume? Increase in afterload should reduce stroke volume, right? If you reduce stroke volume, what happens to the amount of blood that sits within the ventricles now? You should now have a higher end systolic volume. You should have more blood within the ventricles sitting there because less blood is being ejected out. If there's a higher end systolic volume, that means that there's more blood within the ventricles. So more of it stays here. And if more of it stays here, what will that do? That'll try to smash this obstruction down. And so what it does is it tries to decrease the obstruction. And whenever you decrease that obstruction, what would that do to the intensity of the murmurs, my friends? That would decrease the intensity of the murmur. So you just want to think about it in that fashion, that if someone has a higher afterload, that means that their ability to get blood out of the heart is going to be less because now that ventricle has to work against a higher resistance and higher pressure. If it has to work harder to push blood out against it, that might be a problem. And if it doesn't get as much blood out, that means more blood stays within the ventricle. If more blood stays within the ventricle, it can potentially stretch that obstruction out and potentially open it up and reduce the intensity of the murmur. What kind of things would actually work to increase afterload? So they can give you these things called hand grips, and you just squeeze the living life out of it. Hand grips particularly work to increase the vascular resistance. So they try to stimulate systemic vascular resistance, and if you increase systemic vascular resistance, you increase afterload. If you increase afterload, you drop your stroke volume. Less blood exits the heart, more blood stays in the heart, relieving the obstruction. That's pretty cool, right? I think so. In the opposite scenario, we can obviously go in the opposite. A reduction in afterload means an increase in your stroke volume. That means less in systolic volume. Less blood is actually within the ventricles now. So if there's less volume of blood within the ventricles, are you going to be able to have as much of that volume to stretch out that obstruction now? No. And so now because of that, that would potentially worsen the obstruction. And if that happens, and you increase the obstruction, then that is going to do what to the murmur? That will increase the intensity of the murmur. What kind of things would particularly work to reduce afterload, my friends? It's a dumb thing, but sometimes they put it in the textbooks. It's a drug called amyl nitrate. Okay? Amyl nitrate, but you can give really any kind of like vasodilator, really any kind of drug that causes vasodilation. If you give a drug like amyl nitrate, you give something like hydralazine, you give something like isosorbide dinitrate, these things are going to do what to your systemic vascular resistance? They're going to vasodilate the vessels and reduce your systemic vascular resistance. If you reduce systemic vascular resistance, you reduce afterload, you therefore increase stroke volume, and then again, help to do what? Increase the intensity of the obstruction. So it may seem counterintuitive, but when you go through this process, it really helps to make sense. So at the end of the day, if I were to say, okay, patient has HCM, I have them squat or do a passive leg raise. What does it do to the murmur? It will decrease the intensity. If I have someone who has, again, I have them do a Valsalva, I have them do a standing process, That's going to do what to the preload? Reduce it, and that's going to increase the intensity of the murmur. That works because of the whole volume process. Same thing. If I increase my afterload by hand grips, what is that going to do? That's going to cause the stroke volume to drop. Stroke volume drops, more blood stays in. That actually does what to the intensity of the murmur? Decreases it. If I have someone vasodilate their vessels like amyl nitrate, hydralazine, isosorbate dinitrate, something of that nature, it's going to reduce their afterload, increase their stroke volume, and again, what's that going to do to the amount of blood that's in there? Decrease it, and that's going to increase the intensity of the obstruction. Now that we've gone through this process, and it's very painful, let's go through the diagnosis. All right, so we're going to diagnose a patient with HCM. It's not a clear-cut diagnosis. It's not one of those things where someone's going to come in and you're like, oh yeah, that's HCM. It's not too common. Sometimes some of those symptoms that they can present with are very non-specific. Sometimes they can be completely asymptomatic and never ever know that they have hypertrophic cardiomyopathy until they go out, they exercise, they're working really hard, they're increasing the stress and the demand on their heart. And then again, they develop that severe dynamic obstruction that reduces blood flow significantly, cause them to have an ischemic event, and then go into VTAC, VFib, sudden cardiac death. But for the patients who present with the non-specific symptoms, such as dyspnea on exertion, syncope, chest pain, things like that, these are things where we commonly order a chest x-ray and a 12-lead EKG. And the whole point of doing that is to really rule out other disorders. But if we did do a chest x-ray on a patient with hypertrophic cardiomyopathy, what could we find? No non-specific symptoms, but you may see some left atrial enlargement. Remember I told you the left atrium has to get jacked up on steroids to be able to push blood into that thick and non-compliant left ventricle. Sometimes that could be potentially obvious. But again, you're not really going to see any other obvious signs on a chest x-ray. There's nothing that really pops up like, oh yeah, that's definitely HCM. It's really ruling out other particular causes. If you get a 12-lead EKG, you're doing it because they maybe have chest pain, right? They have angina, they have dyspnea on exertion, they have a syncopal event. And really, what could you find? You could find a ton of different things. You may, worst case scenario, find them in VTAC or VFib. You know what else? Is when they get that left atrial enlargement and left atrial hypertrophy, something else really interesting happens. You alter the electrical remodeling process. We didn't talk about that. If you have a thicker ventricle, a thicker atria, it's thicker, it's enlarged, you stretch out that myocardium. When you stretch out the myocardial cells of the atria do not like being stretched. And because of that, you alter their electrical activity and increase the risk of them forming arrhythmias of the atria. What is that called? Atrial fibrillation. So it could also increase the risk of atrial fibrillation. So don't forget about that. So if you got a 12-lead EKG, you might find these arrhythmias. It'd be scary to find this, but it's possible. And again, you can find things like atrial fibrillation. The other thing that you could find, but again, it's non-specific, is you may see signs of left ventricular hypertrophy. So they may have very large R waves in their V4, V5, V6, and then kind of these deeper S waves in V1, V2, V3. The last thing that you may also see is you may see these deep Q waves, okay? And these Q waves usually show up in your inferior leads, right? So you may see these in 2, 3, and AVF, and they may show up in your lateral leads, like 1, AVL, V5 to V6. So these may be also some things that you could potentially see. But again, these are all really non-specific things. So I wouldn't really spend too much time worrying about these. Just realize if a patient comes in with angina, they come in with dyspnea on exertion, they come in with a syncopal event, or they come in with palpitations, you're likely going to order these tests. And these could be things that you find, but they do not diagnose HCM. What does diagnose HCM? Echocardiography. All right, so again, when we're thinking about the echo, what are we specifically looking for? Again, you want to think about a couple things. One is the diameter of the lumen, right? So the diameter of the ventricle cavity, right? The next thing you want to think about is wall thickness. And then the next thing you want to think about is ejection fraction. Okay, these are a couple of the big things. Diameter of the left ventricle, the lumen. What do you think? That sucker narrow, man, right? Same thing over here. Super narrow, super narrow. So really it's a small diameter of the left ventricle. That's pretty easy, right off the get-go, I can say they got a small diameter, and that's because of this asymmetric like septal hypertrophy. But again, there's generalized concentric hypertrophy, just more so within the interventricular septum. What about that wall thickness? What about that thickness? Well, look at it. Look at that left ventricle. It's pretty thick. It definitely has a thick free wall, but there's way more thickness involving the interventricular septum. So there is that interventricular septum that is really, really thick. So they have an asymmetric hypertrophy that is involving their interventricular septum, but their free ventricular wall is a little bit thick as well. Okay, so we have a very thick ventricular walls, but particularly which ones? Asymmetric hypertrophy of the interventricular septum, a reduced diameter. What about that ejection fraction? Now, you may think that because they have that dynamic obstruction, their ejection fraction is low. But actually, remember, you have a lot of myocardial cells. A lot of myocardial cells, they're hypertrophied. You have an increased number of them. You got a lot of cells that are going to be able to contract super hard and are actually hypercontractile. So your ejection fraction in these patients are pretty high. They have a very good contractility, and so their stroke volumes are going to be good. Their diastolic filling process may be a little bit reduced, but they're pretty good at being able to get blood out. And so their ejection fraction is often normal. Okay? Often it is normal. So these are the big findings here, is that they have very thick ventricles, particularly asymmetrically of the interventricular septum, a very small diameter left ventricular cavity, and their ejection fraction is often normal. Again, they do not have issues with being able to eject blood. There's no systolic dysfunction. There is diastolic dysfunction, decreased diastolic filling, but their ejection fraction is preserved. That is a big difference there. Other things that you may see though, right? What are some additional findings that you could see for these patients? Again, if you throw Doppler on these bad boys, you may be able to see that systolic ejection murmur via the dynamic obstruction. You may be able to see that mitral regurgitation as well. So these are big things to be thinking about. Okay, so now that we've done that, we understand what we would see on the echo. What is the last thing to think about that you have to ask? You gotta go and you gotta do a good history. You wanna know, okay, what is the particular things that I'm really looking for to elucidate from these patients' history? What I'm looking to elucidate is, have they had any syncopal events, right, with, exertion. So they were on the soccer field, they've been running, and all of a sudden they had this syncopal event. That's something to think about. Same thing, have they ever had any issues where they've had any angina or dyspnea on exertion? Angina, some chest pain that is occurring with exertion whenever they were running, up and down the football field, okay? These are things that you want to elucidate within their history. So again, are they less than or equal to 35 years of age with a past medical history of having some syncopal events or some anginal chest pain, some dyspnea on exertion that you see within their past medical history. And usually this exertion is likely to be in athletes. That's really kind of the clinical vignette that you're looking at. And then the other thing is genetic relationships. So is there anything genetically that pops out? In other words, do they have a family history? So in other words, maybe like their dad passed away from sudden cardiac death when he was like 25. Passed away from sudden cardiac death at young age. The reason why that's important is because this is hereditary. This is a genetic condition that is due to a mutation within a particular gene that may be passed on. So again, it could be familiar, it could be sporadic, but if that is the case, you want to be thinking about, is there a 35-year-old or less patient who is an athlete, maybe is having had a history of a syncopal event, they had some chest pain, they had some dyspnea whenever they are exerting themselves, and they had a family member who passed away at a very young age due to an underlying cardiac disease like a sudden cardiac death or a heart attack at a young age. These are things to be thinking about in their history, and that is going to cover the diagnosis. Let's now hit on the treatment of HCM. All right, so when we're talking about the treatment of HCM, I want to think about first, what were the things that we could potentially think about the murmur? So go back to the murmur, right? The things that potentially would help these patients is we want to think about it in this way. treat the patients in the ways that would decrease the intensity of the murmur, right? Because if you think about it in that way, you're reducing their dynamic obstruction. That's the best way of thinking about it. And if you remember, an increase in preload opened up the ventricle, right? You had more volume in the ventricles. More volume kind of relieved that obstruction, okay? What kind of things would increase preload? In other words, increase venous return to the heart. All right. So again, going back to this, if I increase my preload, the whole thought behind that is that I will do what? I will increase my end-diastolic volume and I will decrease the dynamic obstruction. And if I relieve my obstruction, I alleviate some of the symptoms and the problematic issues that come from it. So the ways I can do that is I have to increase my preload. So if I want to increase my preload, I can do this two ways. One of the ways I can do it is I can increase the volume of blood that is within this actual vessels that are taking blood up into the heart. So imagine this is pushing blood up to the heart. Okay? I can increase my volume. How do I increase volume? Stay hydrated. So good amounts of fluids. Avoid being dehydrated. That's probably one of the big things. How do I also prevent any loss of fluids? So obviously giving fluids, avoiding dehydration, and avoiding diuretics. Because you know, utilizing diuretics are going to definitely be a problematic issue because you're peeing out volume, and that could drop your actual volume. The other thing that I want to think about with increased preload is I want to increase venoconstriction or prevent any types of venodilation. So in other words, I want to reduce venodilation. The reason why is if I venodilate, what does that do to the pressure, or actually I should say the resistance within inside of this vessel? Venodilation will reduce the resistance, the vascular resistance, and that will reduce the blood pressure within these veins. And if there's less pressure, there's not enough pressure to push the blood up to the heart. So I want to avoid drugs that are going to reduce venodilation. I don't want to give those drugs. What drugs cause venodilation? There's a lot of them, right? So I want to avoid which types of drugs? I want to avoid nitro. Nitro will cause this dilation process, okay? I want to avoid ACE inhibitors and ARBs because they will also cause venodilation. So if I avoid ACE inhibitors, I avoid ARBs, and I avoid nitroglycerin, those are drugs that are going to prevent any venodilation because I want to reduce that process. So these are things to think about that will help me to maintain a good preload. Avoiding dehydration by taking in fluids, avoiding diuretics, and reducing any types of venodilatory processes, such as avoiding drugs such as nitro, ACE inhibitors, and ARBs. Boom, shakalaka. Let's move on to the next thing. Okay, next thing I want to do is I want to try to avoid any reduction in afterload. Okay, so in a way, I'm saying I want to increase afterload, right? In a way, in the same kind of process. Why? If I increase afterload or I avoid any significant reduction in afterload. So let's do it like this, actually. Let's think about it like this. Let's say that I did. Let's say I have a reduction in afterload. If I have a reduction in afterload, what does that do to my stroke volume? It increases it, right? If I increase my stroke volume, what does that do to my insystolic volume? That reduces it. If I decrease my insystolic volume, I have what happens? Less volume inside of this ventricle. If there's less volume inside of this ventricle, this allows for the obstruction to be more intense, an increase. So this increases the obstruction. If I increase the obstruction, that's going to worsen the processes of this disease. I want to avoid anything that will reduce afterload. I don't want to do this. I don't want that happening. So, in order to prevent any significant reduction in afterload, what would I want to do? Okay, think about this. Here's your arteries. Your arteries are very important. So we have blood that's flowing away. Okay, so now here's your heart, and you want to pump blood out of the heart, all right, into these arteries and down through those arteries. What I want to do is I want to avoid arterial dilators. What are drugs that cause arterial dilation? What are drugs that will cause arterial dilation? First one would be ACE inhibitors, ARBs. These can cause vasodilation. What else? You know, particular types of calcium channel blockers like nifedipine and amlodipine, those would also be due to those kinds of drugs. So calcium channel blockers, and we'll just put in an example here, is what's called nifedipine. These will also cause vasodilation. What else? Hydralazine and isosorbide dinitrate, and isosorbide dinitrate. These also cause vasodilatory effects. So think about these things. I want to avoid these drugs because they're going to do what? All of these drugs work to cause a reduction in the systemic vascular resistance. If you reduce the systemic vascular resistance, you reduce afterload. And if you reduce afterload, you potentially worsen the obstruction. If I avoid these drugs, I avoid any types of worsening of the obstruction. Boom, shakalaka, we good. Okay. The next thing that I want us to talk about is not just how do we give things to increase preload, avoid a reduction in afterload, but let's talk about how do we avoid an increase in contractility and why that could be a problem. All right, let's think about the next thing. We want to avoid a significant increase in contractility. Why is that a problem? We didn't really talk about this before, but it also makes sense. So think about this. If you have an increase in contractility, so in other words, you are having your ventricles have to work really, really hard, and you're increasing the intensity of their contraction. So imagine here we have this ventricle, and we increase the intensity of this contraction. If we increase the intensity of this contraction, we're asking it to really, really squeeze down on that blood. If you do that, you significantly increase that dynamic obstruction, right? It's pretty straightforward. And on top of that, if you increase contractility, you're doing another thing. You're not only increasing the dynamic obstruction, but you're increasing the oxygen demand on the heart because you're having these myocardial cells work harder. And if you increase the dynamic obstruction and you have a high demand because they're having to work harder, oh, this is a recipe for disaster because this can significantly precipitate ischemia. So my question is what kind of drugs can we give to prevent an increase in contractility, reduce the dynamic obstruction, and reduce the oxygen demand to reduce ischemia? These drugs include beta blockers. So one of those drugs would be beta blockers. Why? Because beta blockers will work to reduce heart rate. If you reduce heart rate, that reduces the work on the heart, that reduces the oxygen demand. And if you give beta blockers, it reduces the contractility. And that will also reduce the dynamic obstruction and the oxygen demand. So that's one drug. The other one is calcium channel blockers, but not like nifedipine or amlodipine. This would be like diltiazem or verapamil, because these will block the calcium channels and that will also reduce contractility and reduce heart rate. That'll reduce oxygen demand and reduce the dynamic obstruction. So these are drugs that you'd want to do. What drugs, so these would help to reduce oxygen demand and reduce the dynamic obstruction. What drugs will we, oh my gosh, do not give this because it's going to cause the contractility to increase. Digoxin, right? So do not, in this case, I want to avoid digoxin or any kind of positive inotropic agent. Digoxin, epinephrine, dobutamine, those kinds of agents. Stay away from them because they are going to increase the inotropic activity, increase contractility, increase obstruction, increase demand, worsen ischemia, put a person into sudden cardiac death. We don't want that, all right? Good. Next thing, arrhythmias. We want to decrease the risk of arrhythmias. Because of this ischemia, and it can lead to sudden cardiac death via VTAC, VFib. Look at that, that worked out perfectly. VTAC, VFib. This puts them at very, very high risk because we want to try to avoid them from going into this type of arrhythmia because obviously this arrhythmia is what induces sudden cardiac death. So how do we avoid that from happening? So sometimes what happens is if we have a patient who has had syncopal events, they have a diagnosis of hypertrophic cardiomyopathy, they've had syncopal events, they have ischemic chest pain or anginal chest pain, they've had certain issues where they have dyspnea on exertion, this would be something that you would definitely, and maybe even having some type of like telemetry or Holter monitoring where they've had certain types of arrhythmias that have developed, we should consider putting into them an AICD. So what is this called? An AICD. An automatic implantable cardiac defibrillator, so that if they ever do go into VTAC and VFib, this will shock them into ablate that arrhythmia, okay, that VTAC and VFib. So it'll try to shock it and stop. I shouldn't say ablate because they're not actually like removing or destroying anything. It just helps to stop. So it delivers a shock to try to reset the actual electrical rhythm. So it'll stop the VTAC and the VFib. So this is something that you definitely want to consider in a patient with hypertrophic cardiomyopathy who has had incidents of single events. They have a genetic history, they have a family history, they've had a diagnosis by echo of HCM. Consider putting this in so that they don't develop a sudden cardiac arrhythmia, a sudden cardiac death due to these arrhythmias. All right, so the last thing that we want to talk about here for the treatment of HCM is invasive procedures. Sometimes in patients who have HCM, we've gone through their medical therapy, we've maximized it, they have an AICD, they're at high risk for VTAC, VFib, sudden cardiac death. We may consider them to be a good candidate for something what's called a myomectomy or an alcohol septal ablation. So first thing we can do, it's pretty straightforward, is we could literally come in and surgically cut off this actual thick hypertrophic portion of the interventricular septum. So we can literally come and cut this portion off and help to normalize this to where it actually looks like what an interventricular septum should look like. So imagine we cut that off, and now that we've done that, we have kind of a normal size interventricular septum that's not obstructing the left ventricular outflow tract. What is this called? This is called a surgical myomectomy. Okay? That's one thing that we could consider. The second thing is actually really stinking cool. So imagine here's the interventricular septum. In that interventricular septum, where's my red marker? Here it is. We have some blood vessels that are going to feed this area, right? We have some vessels that are feeding this area. We can use a catheter. So imagine I take a catheter, and in that catheter, I get near this area, and I shoot into this area where the muscle is some alcohol. You're like, what? So I'm going to utilize some alcohol. I'm going to shoot alcohol into this area. What does the alcohol do? So what is this procedure here called? It's called an alcohol ablation. And it's kind of like catheter directed. What happens is we utilize this vessel, we squirt some ethanol into it. And what happens is that gets into this myocardial cells. Remember what I told you back from dilated cardiomyopathy? That lots and lots of alcohol that's concentrated into the myocardium is what? Cardiotoxic, my friends. And it starts causing destruction, yeah, of this myocardial cells. If you start causing destruction of the myocardial cells in this directed area, guess what you're basically kind of precipitating or reproducing? You're causing a destruction of this tissue in the same way. You're just utilizing a little catheter and directing the alcohol into this area of that interventricular septum and causing alcohol to get in there and destroy these parts of the interventricular septum. And eventually, if you do that, you may create a normal size ventricle after that tissue cells actually completely become dysfunctional and die off. And then we normalize and we relieve, because now if this area isn't able to contract, are we going to have this thing kind of bowing in and blocking the left ventricular outflow tract? No. And so you relieve the obstruction. So this is another thing you can consider. So invasive procedures include a surgical myectomy or a septal ablation utilizing intracatheter types of alcohol release. My friends, this covered hypertrophic cardiomyopathy. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.